say we've done our template and we have us a game plan going into the OR. We always need a game plan. But before we get too far, uh, what approaches are out there? Which ones do you prefer, and why do you prefer them?
Sure. There's tons of different approaches. Kind of the mainstays of the anterior approach, or direct anterior approach, anterior lateral approach, direct lateral approach, and then the posterior lateral approach. Um, I don't do the lateral approach or an anterior lateral approach that much. The risk of the lateral approach is denervating the abductors, and they get kind of a Trendelenburg gait. My personal, I know there's a lot of people who do a very good job with that approach and a very low risk of limp. All the times I've done it or seen it, it's had a limp. So my thought process is, I want to do an approach that I don't want the patients to limp afterwards. My goal is for them to walk as normal as possible. So I do both posterior and anterior approach. Um, Anterior approach traditionally has a little bit higher stability, so a little bit lower dislocation rate. It's a little bit faster recovery, though not beyond 6 months. Posterior approach is kind of more traditional approach. Um, there's better access, a little bit more visibility, and a little bit more extensive. Although you can extend an anterior approach if you're experienced with that. Um, and then I think when patients ask me about posterior versus anterior, I like doing anterior more. I think it's a little more fun. But I'd be hard pressed to tell them is there any significant difference in outcomes beyond about 6 weeks after surgery.
Okay. And so, what about, say, if you have a fairly large patient, a patient with a big pannus? Does that change any thoughts on as far as which approaches you might choose?
Yeah, with a bigger pannus, I'm probably going to lean more towards going posterior. Although, if you guys have gotten a chance to do many anterior approaches in residency, you kind of realize that there's not a whole lot of people that are real thick over where the anterior approach really goes. But the big part about the pannus is I don't want a big belly or anything pushing down on the incision, and I don't want the incision trying to heal in like a sweaty bodily crease. So I might be a little bit more prone to go posterior. I think bigger people the bigger a person is, the heavier they are. It becomes more challenging no matter what approach you go. But I tend to lean more posterior for that.
Yeah, I think it's really awesome to have both of those in your repertoire just in case, because I feel like like you said, that large panic sometimes it just that lapping over the incision, I don't know, that could cause wound complications and things like that. So if you have the posterior in your repertoire too, where you can do that and not have to worry about that as much, is great to have. um Man, Dr. Short, have you ever smelled fear?
Absolutely.
Watch this, Dr. Short. So, Cody,
Well, go ahead. I'm listening. What are you gonna
which
say?
which nerve are you worried about? It's like classic in the anterior approach, right? And which one are we totally worried about that you might knock out? And some of the doctors who worry about posterior approaches, who only do posterior approaches, this is like their only knockdown to the anterior approach. Like, oh
You,
yeah, this what
you
you have to
mean
worry about.
the lateral femoral cutaneous nerve of the thigh? That's what you're thinking of for the anterior approach?
Dr.
Nailed it.
Short, I had to go slow and so that he had enough time to Google it. I didn't want to make him look bad on live on live on the podcast. But
Well,
yeah,
You got it right on. I
yeah,
tell all my patients I do an anterior approach on, you're going to have some numbness in that distribution. Majority of the time improves by 6 months. If you look at the studies, when you specifically ask patients about lateral femoral cutaneous nerve issues, 80% of them will have it. If you don't ask it, 15% of them bring it up. So I always tell them, you are going to have it. It's not, a functional limitation. And, knock on wood, so far I haven't had any patients with any long-term issues with it. The other risk of the anterior approach relative to posterior is a higher risk of femur fractures, both intraoperatively and in the first couple weeks postoperatively, which is largely related to kind of the angle that you have to broach it. And I think it can be largely mitigated by being careful, but it definitely does happen.
okay. And yeah, so what do you think or I'm pretty sure, I hate stating things and I'm not 100% sure, but as far as long-term outcome with all these approaches, is there really any difference in the long-term outcome for these patients?
No, I don't think so. And I have patients asking for anterior approach, and we'll talk about posterior approach, and I tell them, I think a well done posterior approach and a well done anterior approach with modern components, modern techniques, and a posterior capsular repair if you have a posterior approach. I don't think there's going to be any long term difference between the two of them. I think if you've got a surgeon that primarily does posterior, you should have a posterior. If you've got a surgeon primarily does anterior, you should do an anterior. If you got a surgeon does both, then you can pick what you want to do. You know, asking a posterior surgeon to do an anterior or an anterior surgeon that doesn't do a lot of posteriors do a posterior is kind of like going to a steak place asking for lasagna. You know, you should go with whatever's in their wheelhouse.
Yeah. Yeah, like you said, I definitely think it's just depending on which ones is best in their hands. But for some reason, I feel like patients think the anterior approach is like better. They feel like it's more, I don't know. I don't know if they think it's better or it's less
Maybe the
invasive
scar.
or something. Yeah, it's like people come in kind of asking for that. They heard about it and they want to, you know, but I don't know.
It's definitely definitely out there. Patients come in looking for it, asking for it. They're looking for people that do it. Honestly, I tell them flat out, I was like, I don't think it's necessarily better than a posterior approach once you get past first 6 weeks. You know, the earlier recovery is a little bit tempting to a lot of people. I think in a lot of situations, a lot of areas, it becomes more of a marketing but a marketing, you know, tool.
Like a tactic, a tool, yeah.
Yeah, I mean, all of my, you know, I had 5 co-fellows. Every single one of them that, you know, when they're applying for jobs, they got asked, "Do you do an anterior approach?" And places want an anterior approach just to have it because they don't want to lose patients that want to go somewhere else for an anterior approach.
Something to think about there, and think about that. But yeah, okay,
Yeah, for sure.
that was good. I think that was a great great overview as far as